Good morning, good afternoon to all of you. Thank you for Dr. Rivera and Dr. Crochet for having me, for inviting me to this, for me, very special event. Latino America is another world for me, for ESPGHAN. And I was quite excited to hear from the invitation. As a brief reminder of where we in ESPGHAN and where personally I come from, I've put a map here. You see the bottom red spot is where Professor Kolacek comes from, the current ESPGHAN president. The next spot is Hanover. This is from where I speak today, and the other spot is my second affiliation in the UK, is Birmingham. And Hanover, you may never have heard of Hanover before. Generally, it's known from the kings who were elected to become the kings in the UK, in the United Kingdom, and this had a centenary anniversary just last year. I have a couple of conflicts of interest which I would like to share with you on this slide. We're talking about abnormal transaminases. That's hopefully not too boring to you. I feel it is important to talk about this topic also, not only to general pediatricians, but also amongst ourselves, amongst pediatric gastroenterologists and hepatologists. I would like to provide some background physiology for elevated serum transaminases. I would like to discuss the implications of these in different clinical scenarios. And I would like to introduce a rational approach for the diagnostic workup of persistently elevated abnormal liver function tests, or formerly aminotransferases. Now, we generally call all these in one bag. We'll call them liver function tests. But I would like to draw your attention to the fact that, in fact, when we look at the liver and at the blood tests we do for the liver to assess the liver, we need to distinguish synthetic function. This is the key. This is obviously the clotting, but it also is the fact, is the liver able to maintain the glucose homeostasis? Is the liver able to produce sufficient albumin? And things like that. Is the liver able to support normal growth of a child? All this is summarized in synthetic function. Then there is cholestasis as a pathophysiological situation. And I would like to call that an emergency. Anything related with cholestasis is urgent. And then there is cellular injury, and that's a bit dodgy term. It can mean anything. It may mean full necrosis in acute liver failure, but it may also just be the vaccination from COVID-19 or some other routine vaccination of an infant. The other question we like to ask when talking about liver function tests is, does it help us to distinguish acute and chronic liver disease? And the answer to this is not quite easy, and it's generally difficult to distinguish. Now, what's on offer? We have the aminotransferases, the transaminases, aspartate aminotransferase and alanine aminotransferase, the glutamyl, gamma-glutamyl transferase, the alkaline phosphatase. Never just do the bilirubin, do split bilirubin, conjugated, unconjugated. Clotting is important, and I quite like factor 8. Now, that's a bit fancy. A factor 8 is expensive, but there are some rare situations when I feel it is helpful to distinguish platelet consumption and clotting factor consumption in a state of sepsis, for instance, from acute liver failure. INR and platelets may be down, and you may think this is sepsis, or you may think this is genuine liver failure. And factor 8 is the one test to help you distinguish. In case of consumption, factor 8 will be low as well. In case of genuine liver failure, factor 8 is usually overcompensated of well over 100, sometimes over 200% of normal. Extended liver function tests I see also as full blood count, glucose, usinase, and the lipids, triglycerides, and cholesterol. Now, as a reminder, aspartate aminotransferase comes mainly from muscle, but also from erythrocytes. 80% in the liver come from mitochondria. Alanine aminotransferase is predominantly liver. Now that's important when you want to compare, does it come from muscle? Is this muscular dystrophy or is this hemolysis? An important source for transaminases is cellular leakage, and this is very common, can just be, may just be exercise. It does not have to be the marathon. It can be any exercise on the playground. Inflammation in all sorts, hepatotropic viruses or not, trauma, bruises from playing, surgery, vaccination, and not least necrosis. We talk about the origin, but we should never forget the clearance of these enzymes from the bloodstream, and this is not cleared. Very few enzymes like amylase are cleared by the kidneys. The majority is cleared by the reticular endothelial system. And this is something that can cause inhibition there, may cause increased levels. Persistently elevated aminotransferases, we generally talk about them in cases of elevation over 6 months and more than 1 times 5 elevated above the norm. Now, first case scenario, and you all think about what you say. I would love to interrogate you here in person, but I'm sorry, I cannot be. You'll be glad that I cannot interrogate you. But seriously, think about this scenario. Laura is 14 years, a well adolescent. There's no history of note, but the lab values are persistently abnormal. And it sticks out. This AST is abnormal. The ALT is okay, gamma GT, AP, this is all fine. Any guess? Make sure that the CK is normal to make sure there is no muscular problem, but the macro AST seems the likely diagnosis. This is a polymer of AST, and this increases the half-life of the enzymes in the bloodstream. It just persists for much longer. Hyperphosphatase is another example for the pulling together of many of these molecules in one big macromolecule, and they are more resistant to breakdown, and therefore they produce high numbers in our blood tests. Talking about half-lives, what is normal? AST is 12 hours, ALT is 2 days, so considerably longer, and the others, for instance, quite long. You need to think about this in case you, for instance, want to use a cholinesterase in acute liver failure. Do think about a 14-day half-life, so the patient is fully recovered until you see a change in the blood test. Now, what really we want to know, can these transaminases tell us to identify from this lovely, healthy liver, which is a donor organ, and help us to distinguish from this cirrhotic end-stage liver disease? And the way I ask, I think it's clear, no, you cannot. But can aminotransferases help us distinguish? Yes, they may, but more importantly, they can not only tell us good or bad, they can tell us to help identify a diagnosis. 3 examples for this. 3 case scenarios. And again, you think about the answer. What do we see? We see a 10-year-old girl with persistently abnormal. All of these have been at checkup before, and this is persistent. So transaminase is quite high. Alkaline phosphatase, I would say, within the age limit. Bilirubin, okay. And the PT is slightly prolonged. You may think, could be vitamin K deficiency, but it persists like this in the long run. So a hepatitic picture in a 10-year-old girl may well be autoimmune hepatitis, and this is what was confirmed when we biopsied the child. This child had cirrhosis. 13-year-old boy, our second case. Transaminase is much lower. Gamma GT, neither here nor there. Alkaline phosphatase, 43. What do you think? Is that normal for a 13-year-old pubertal boy? No, it's not, isn't it? It's low. And the bilirubin, again, something above the cutoff. And again, the PT is prolonged, so there seems to be significant liver disease. Now, the diagnosis, the suspected diagnosis, is in this figure. And this is the key, is the alkaline phosphatase, and the key is the lowest aminotransferases. This child, again, had cirrhosis, but this was secondary to Wilson's disease. Alkaline phosphatase is notorious for such low numbers, low figures, because it contains zinc. As iron is part of the hemoglobin, zinc is part of the alkaline phosphatase molecule. And you all know that in copper toxicity, you get very low zinc levels. That's the principle why you treat patients with zinc, to balance the two metals. And also, which is important to know, that Wilson's does not have this strongly hepatitic picture. You have much lower transaminases in general. They may not meet 2 digits, but it's much lower. It's not this hepatitic picture from the girl before. So, and again, the transaminases did not really help you. Both children were cirrhotic. And the last child, 16-day-old neonate. Hey, what is this? Does this child have liver disease at all? Normal transaminases? The key to this is the INR, which is very prolonged, which is abnormal despite vitamin K. And this alone, the high INR, gives you this, or in combination with the normal transaminases, makes you think of exactly neonatal hemochromatosis. Very typical picture. And just to point out, all 3 patients were genuine children that we looked after here. All 3 had cirrhosis. This liver comes from the last child at the time of transplantation. And you see they all had cirrhosis, and the transaminases were very variable. So I hope I could convince you that you really need some more information to interpret the blood tests. You need to know the age. The first child was a girl. A young girl fits well into autoimmune hepatitis. So you need some background information. And when you think about history taking and physical examination, I cannot go into too much detail here, but the 3 key questions are on the left side of this slide. You want to find out, is this primary liver disease, or is the liver just the victim of some other problem? Is there, I'm sorry, there's some German left in here, apologies for that. Is there some cardiac insufficiency? Is there right ventricular problems with a return problem to the heart? Is there oncology? Could there be leukemia, for instance? And a harder question to answer than one thinks, is this acute or chronic liver disease? And you look out for things like portal hypertension, pulmonerethema, or spider needle. And then once you've made up your mind, you want to find out, are there associated problems? For instance, is there metabolic bone disease, rickets, or cerebral edema? And the items here on the right-hand side will help you to decide on these questions further. Now, having done that, another scenario for you to consider. Steve, 13 years, he's not really bothered. His mother sends him, but he doesn't feel he needs a doctor. Comes on his own. He's jaundiced, and that's what worried the mother. It's the first time at the age of 13. He's well, although when you ask him, he says, I occasionally have some tummy pain. Stools? Yes, you ask. Any evidence for cholestasis? No, there's no evidence of cholestasis. Physical examination otherwise is unremarkable. So what's your diagnosis? What's your suspected diagnosis? A little bit early for that. What tests are you asking for? What tests? And we're talking about transaminases here. Would the transaminase levels be of any help to you? And this is example. No, I don't think they are. The way I'm asking, you can spot that. This boy has Gilbert-Mollengrat syndrome. As a reminder, it's a reduced UDP glucuronidinotransferase activity is very common, 10% of the global population. Bilirubin, very rarely towards 100 micromole per liter. Abdominal pain is common. It's a strong family history. It's usually a dominant trait. It can be in older children or young adults. It's triggered by stress and sleep deprivation. But in theory, you can treat it by phenobarbital. So occasionally I hear from young adolescents also who say, oh, I have an important test, or I want to go to university, I need to get rid of that jaundice to look healthy. You could, in theory, treat it by phenobarbital. Neonatal jaundice is prolonged, so this is something to consider, and the test is quite common. Now, the reason why I present and why I touch on this briefly here now is that the key to the diagnosis is to exclude hemolysis. It's unconjugated hyperbilirubinemia, so you need to exclude splenomegaly. The transaminases are not much use in this scenario. What is this? This is the skin from severe itch. So do consider cholestasis when you see a liver patient like this. And then remember that the skin signs are very helpful, and sometimes the only thing you have to interpret your blood tests. I hope, at least in my camera, this little one is a little bit better. You can see the ring of erythema here on the fingertips, here. Once you've seen it, it's quite a striking feature. And then the telangiectasis is on the cheeks. This is a skin lesion that we increasingly see in overweight and obese children, and this poor girl was very traumatized from her peers at school. Actually, she left school because people said, oh, you're dirty. No, this is not dirt. This is acanthosis nigricans in a typical location. But you won't be surprised when people say, oh, this is your dirty necklace and this is all, you should have a shower. Now, this is an acanthosis nigricans. Equally here on this slide, quite striking. And because NAFLD is so common in this scenario of raised transaminases, hepatomegaly is hard to spot. And the other two are more helpful to spot this. Patients with fatty liver disease and mildly raised transaminases often have right upper quadrant pain. So put this into context, aminotransferases, elevated aminotransferases. What evidence do we have to justify all the tests and all the further investigations? What have other people done to tell us how far to go? And I've put two slides together with epidemiology to illustrate the pitfalls and the need. 20 years back, Strauss in the US looked at 2,450 children, adolescents 12 to 15 with raised transaminases. And he could clearly identify what I just said on my previous slide, that it is much more common the more obese a child is. So this really seems to be elevated transaminases, seems to be an issue of obesity and fatty liver disease. So that's the first thing to remember. The second thing, Urio in Italy looked at 425 children, young infants and babies aged 1 month. He just gave it a little time. 6 months later, the majority, 259, were normal. So good job that he waited. 75 had obesity-associated fatty liver disease. 55 did have defined liver GI disease, but if you look at the 425, this is from 1/8 of them. 14, important subgroup to remember, had muscular dystrophy. So do remember to check a CK when you first see one of these children. 22 were unknown. So There is a small proportion of children that need our help, but a small proportion. This chap, I think also from Italy or France, was more suspicious. I think he wanted to prove that us hepatologists are a bit overambitious. So he looked at 72 infants already pre-screened with transaminases for more than 3 months. He excluded all the expected suspects, all the children post-blood transfusion, the ones with known cholestasis or where history taking already suggested a problem, or when ultrasound had some dubious findings. So he did a good job, a good doctor's job. And he looked at the remainder. 53 normalized the LFTs with further waiting. 3/4 again normalized. 17, then he said, oh, you need a biopsy. 8 of these families refused, 2 canceled, 7 were biopsied, in fact. In 3, glycogen storage disease was suspected, and 4 were non-specific. So that's a challenge for us hepatologists. Are we looking at the right children? And in order to illustrate this further, I would like to point out publications from the recent past, and I would suggest you look at these papers. Very interesting reading, and they formulate a phrase, overdiagnosis. They say children can come to harm if you just do too much, if you do repeated blood tests too frequently, or if you do things like invasive biopsies. And they suggest that you are very careful in the indication for further investigations and don't put children to harm from, let's say, things like liver biopsy. Substantial proportions of children may not benefit from commonly pursued pediatric diagnosis. In some cases, overdiagnosis is necessary to ensure larger gains for the children. However, many diagnostic tests will not bring you any further. I have 2 children that I would like to present to you to put these articles into proportion. So this girl was referred from a different center, and they said, oh, this is fatty liver disease. You just lose weight and things will turn out and all fine. We don't do anything. This girl, in fact, had celiac disease. And the right girl on here lost a family member, and only then she was referred to us and was diagnosed to have Wilson's disease. So although one has to be careful when to time a biopsy, it's a fine balance, and the answer is usually in your history taking and in perseverance. Sometimes, and in particular with transaminases, it's very okay to wait. For cholestasis, you need to be quick. That's a red flag. But for transaminases, in the absence of any other problem, you have more time and you can watch and wait and observe further things like splenomegaly, etc. This is a suggested mechanism how to do that. So when you see these raised AST/ALT, what to do? You look for red flags in the history. For instance, is there a family history of note? Or do you happen to have additional blood tests like autoantibodies, splenomegaly, skin signs? Is the child cholestatic? Then you pursue and you move on to further testing. If the answer is no, you consider other explanations. Is there infection? And I'm sure in Latin America you have many things that I can learn from you and that you are very familiar with as an explanation. Viral hepatitis in the area where I come from is rare in children now, but there are so many hepatotropic viruses and bacteria. It's worth to considering these in the first line. sports myopathy, vaccination, injection, many reasons for leakage of the membranes. And then obesity, we heard, and if so, these patients need a lifestyle recommendation. They need to lose weight. Give it 6 months or less, depending on the clinical scenario, if you are concerned, but give it time. And only then recheck. If the AST is still elevated, you have persistently elevated transaminases, and you need to start with some workup. Exclude things like cytokine keratase, creatine kinase, and at the very end, you need to consider mutation analysis. And in my center here, we do mutation analysis at a relatively early stage these days. This is the stepwise approach that I would recommend. It starts with very simple things. We exclude hepatitis A to E. E is very popular here in Europe these days. Not sure how common alpha-1 antitrypsin deficiency is in your region. We like to do autoantibodies, including celiac disease, which is so common that we often find celiac disease as an explanation for abnormal transaminases, ceruloplasmin, and TSH. And depending on the outcome of these non-invasive tests, we then would consider a liver biopsy. So what can we learn? How can we summarize what I tried to put together in this last half an hour? Persistently elevated aminotransferase levels are common. And because of that, they are a challenge for us as hepatologists. We are asked, we are looked at, does this matter, or is this something we can ignore? In the vast majority of cases, etiology is harmless and temporary. However, if persistently elevated chronic liver disease needs to be excluded, and although I told you about overdiagnosis, don't leave a child with persistently abnormal transaminases indefinitely. You have a lot of time, but don't leave it indefinitely. And I would push for at least mutation analysis, if not a liver biopsy at some stage. And that may be much delayed. Consider your red flags. Is there anything that worries you? And then do it quickly. Otherwise, you have time. Do an individualized approach. There's no standard recipe how to avoid overdiagnosis, but just be conscious that this is well described these days, and try to leave your invasive diagnostic tests towards the end. Thank you very much. I hope I will be available for questions, but if not, you could drop me an email. It's baumann.eu@mh-hanover.de. It's been a pleasure to be here, and I wish you all the best for your future career, and perhaps we hear of each other. All the best.